Our next esteemed speaker is Dr. Banshi Saboo. Banshi Saboo is a chief diabetologist and chairman Diabetes Care and Hormone Clinic at Ahmedabad. He's president of RSSDI 2019-20, president of AIARO 2016-20, honorary secretary of Diabetes India and honorary secretary of Diabetes in Asia Study Group, launch a project Diabetes Free India in 2013, acknowledged by the president, expert of RSSDI guidelines for management of diabetes, more than 112 publications and fellowship of several professional bodies. I would like to invite Dr. Bharat Saboo, Dr. Raka, Dr. Abhishek. Dr. Bharat Saboo, please initiate the session.
Thank you, sir. A very warm good afternoon to everyone. First of all, I would like to thank Dr. Manoria, sir, for including me in this wonderful second global cardio-metabolic update. This is really indeed a wonderful program. And from one good lecture, now we are coming to another, the mother of most of the evils, obesity. So to take it, none other than my elder brother, Dr. Banshi Saboo. Over to you, sir.
Thank you, Dr. PC Manoria and organizing committee and scientific committee for giving me this opportunity to talk on a very important topic, which are GLP-1 receptor agonist, dual, and even newer GLP-1, which will be in the pipeline. In next 15 minutes, I'm going to complete these three newer molecules, which will be there in near future. As we know that diabetes is because of unhealthy diet and physical inactivity, but the biggest driver for diabetes is an obesity. 1 in 3 diabetic patients is an overweight and 1 in 10 is obese. Probably it is more, as we are top 10 fattest country in the world. After US and China, probably we are one of the highest number of persons with obesity. How we can prevent, as per World Health Organization, it is the healthy eating pattern, the physically active, avoiding the weight gain, and checking the blood sugar regularly and following the medical advice. I think probably we can prevent. And the government has to create a healthy environment to ensure a better diagnostic and treatment and a better data for prevention of obesity and diabetes. The importance of obesity management is that sustained weight loss of more than 15% weight loss has a major effect on a progression. Rather, I can say with 20 and 25%, it can create remission in large proportion of patients. It markedly improves metabolic status. It also improves metabolic function, better overall functioning, and increasing the quality of life. The goal of pharmacotherapy in obesity management, or I will say it's a diabetes management, is reducing the hunger and food cravings. It improves physical functioning, so activities become possible or easier, and improve the adherence to behavior change. This is one very interesting paper of Dr. Michael Nock, who has talked about incretin hormones, their role in health and disease. One more paper, which is on twin creatine, that is what I'm going to talk today, from GLP-1 to twin creatines. The diabetes and obesity treatment is based on this dual incretin receptor activation, because not only they have the GLP-1 co-agonist, but they also have a selective GIPR, which is very important incretin, which is dually, if we can have the receptor activation, probably the weight loss is very, very significant. These many molecules, which will be in near future, GLP-1 and GIP, along with that, now the triple combination is also coming, which is glucagon. If we have the combination, these many molecules are in phase 1 or phase 2 trial. Some of them had reached up to the phase 3 trial, which we will be talking. Eli Lilly molecule, which is already having its cardiovascular outcome trial also. So these are the molecules which will be in near future, maybe another 5-10 years we'll be having all this. But let me start with the Liraglutide. That was Dr. Manoria had asked me to start with Liraglutide, Semaglutide, then Tirzepatide, and then the further molecule. So the effect of liraglutide is, which is already been approved as an anti-obesity agent. We know that it's in GLP-1 receptor agonist, which is an anti-diabetic molecule, but in 3 milligram in persons with obesity or persons with diabetes and obesity or with pre-diabetes, the weight loss is significant. This you can see here after 56 weeks or 58 weeks in a person with weight loss or with obesity. This is significant number of patients who can reduce their weight, and at the same time the weight loss was around in the tune of 8 kg or somewhere around 10 kg. This is liraglutide 3 milligram, 10% of the weight loss. The second big molecule which had come from Semaglutide, which is 2.4 milligram, is an approved for obesity treatment. So I was talking of liraglutide 3 milligram for obesity management. The Semaglutide 2.4 milligram for obesity treatment. The global phase 3 trial was there for weight management in step 1. In step 2, it was weight management in type 2. In step 3, it was weight management, and in step 4, it was sustained weight management also. The patient with step 5 and step 8 was long-term weight management, and step 8, it is head-to-head with liraglutide also, it was compared, and then you can see the data. The step 1 had shown in 68 week 14.9% weight loss. I mean, something which we never thought that a drug can reduce the weight by 15%. In step 3, which is baseline to week 68, it is 16% weight reduction. In step 4, it was at 20 weeks, the data is showing 10.6%, and in week 20 to week 68, and a further reduction was again by 7.9% in step 4 trial. So you can again see step 1, step 3, and step 4. Step 1 was primarily for weight management, step 3 was primarily a weight management drug, and step 4 was a patient with sustained weight management loss. How was the weight loss program with the semaglutide? What about when we compare it with liraglutide 3 milligram? Both the molecules is an anti-obesity agent. You can see here the observed change from baseline over a period of time. The patients who were put on a semaglutide 2.4, if we compare it with liraglutide 3 milligram or this, you can see here it is 6.4% reduction, while here it is 15.8. The trial product estimated here it was 6.6, while it was 17.1%. So you can see how significantly the semaglutide is more powerful, more effective as far as weight reduction is concerned. This one more paper which has been talking the same thing, that how weight loss was more than 5% was achieved. Almost 87% of the patients who were put on semaglutide in compared to liraglutide, which was 58. Those patients who are reducing weight by more than 10%, against 70% of the patients who are on semaglutide were actually reducing. More than 15% weight reduction was there in 55.6%. And more than 1/3 of the patients could reduce their weight by 20%. So you can see how semaglutide is effective as far as weight reduction is concerned. The safety and tolerability is always a challenge when we are talking of a newer molecule, but now we have oral semaglutide available to us. Internationally injectable is available. It is well tolerated. Some GI side effects is expected. Few participated had shown an acute pancreatitis or gallbladder related disorders, but very few, and no new safety concern related to diabetic retinopathy or hypoglycemia is given after the step 2 trial data. So this is very important, that it's very safe and tolerable. Now this is very important in newer molecule, which is dual GIP and GLP agonism. This is Tirzepatide, which is a SURPASS program. It is a SURPASS 2, SURPASS 3, 1, 2, 3, and 5. These data which I am showing here. This is a dual GIP and GLP. Here you can see the patients who are put on the molecules with a full dose. It was almost in the tune of 9.5 with the baseline weight reduction was 85.8 kg in 40 weeks only. You can see 9.5 kg reduction was there. So almost more than 10%. In SURPASS 2, the weight was baseline was 93.8. Again, here it was weight reduction was 12.4. In the SURPASS 3, 52 weeks trial, full 1 year, it was baseline weight was 94 kg, and again you can see the tune of 12.9 kg weight reduction, more than 10%, 15%. Surpassed 5, baseline weight was 95.3 with a 40 weeks, again a weight loss of 10 kg. So this is what the data of Tirzepatide, which is inhibiting GIP and GLP both. This is the data of the same twin creatine of Tirzepatide, which is talking of weight reduction significantly in compared to the patients who are on Liraglutide, which is a GLP-1 analog once in a week, in compared to that a twin creatine or a Tirzepatide is reducing weight significantly. The safety and tolerability of Tirzepatide is overall safe. It is almost consistent with other GLP-1. Most frequent GI side effects are there. It's mild to moderate, but it's transient. Discontinuation of drug is done in very less number of patients, 3 to 1 kg, 3 to 11%. Hypoglycemia was low in Surpass program as it was not continued. Tirzepatide was not continued with sulfonylurea or insulin. So that's what the best part, that it was not given. So less risk of hypoglycemia. This is what the weight reduction in 16 weeks you can see significantly, and it was continuous. And for 16 weeks here you can see till they get plateau, you will have continuous benefit of Tirzepatide as far as weight reduction was concerned. This is a really new molecule, a Cagrisema, a human amylin analog. This neuroendocrine peptide, a co-secreted with insulin from pancreatic beta cell in response to food intake, acts as a satiety signal, shows gastric emptying, suppresses the postprandial glucagon response also. And this molecule had reduced the weight, you can see versus Liraglutide also. It is reducing 10.8 kg. So that's a very, very significant reduction in Cagrisema versus Liraglutide or versus placebo as far as change in body weight, but only 26 weeks data, a significant weight reduction was there. When I compare it with the one Cagrisema with Semaglutide, if we can combine these two molecules, the weight reduction is further decreased, and that's only in week 20. That is 17.1 kg. I mean, just you imagine, for those patients whose baseline weight was around 85 or 90, it's almost like you are doing the gastric bypass sort of surgery. The most common adverse effects of this Cagrisema is GI. It's a dose dependent. The injection site reactions were dose dependent. All mild to moderate led to treatment discontinuation. The anti-Cagrisema antibody increased with dose and time, so no association with immune complex disorder or severe allergic reaction. Few cardiovascular events, no evidence of dose dependency, transient increase in aldosterone and renin activity are not associated with increase in blood pressure. And there are some 5 malignancy events which was there when we combined it with Cagrisema with Liraglutide. Liraglutide was also having 1, and it was 2 with that, and 1 patient was there with placebo. So as peptide conjugates, it is a golden therapy against obesity. This is not only at the level of brain, where it gives you the suppression of appetite, it is also at the level of GI system, it also at the pancreas, liver, adipose tissue, and everywhere it is going to have the effect. So the future direction, the gut hormone polygonism for the treatment of type 2 diabetes, one is a GLP-1 and glucagon co-agonist. They are going to improve the body weight, energy expenditure, glycemic control, and cholesterol. The GLP-1 and GIP co-agonist improves the glycemic control, body weight, lipolysis, and cholesterol. Last, which is very important, the triagonist, which will be the future, which is going to have major effect on body weight, glycemic control, lipolysis, cholesterol, energy expenditure, and increasing the lipolysis. The incretin therapies will be in future. Already oral Semaglutide, which as we have, but I'm sure many more enhancer of GLP-1 secretion will come. That way DPP-4 had come, which is inhibiting the GLP-1 enzyme, but there are enhancer of GLP-1 will come. In future, there will be gene excretion, there will be intraperitoneal pumps and inhalation. Here, the future of combination partner with other gut-derived department like GIP, glucagon, gastrin, peptide bile acids, they all are working in as an incretin-based therapy for a better control of diabetes. But more than diabetes, they are weight-reducing therapy, and they are approved Semaglutide and Liraglutide in USA as a weight-reducing agent too. My concluding remarks will be we must address the bias and stigma against medication and surgery for obesity. Biological adaptation are a huge challenge for people with obesity when it comes to trying to maintain weight loss. Current pharmacotherapy shows great promise like weight loss, cardiometabolic benefits, and quality of life improvement. With this, I once again thanks Dr. Manoria sir for giving this opportunity, and thank you all the participants who are joining digitally. Thank you.
Semaglutide, as you said, has shown excellent weight reduction to the tune of 17% or so. What is why it is taking such a time to come to India?
So that's really a great question. That one of the reason was that GLP-1 in our country is actually available since last almost a decade or more. And you know that none of the molecule could do the great. Even we have the number of diabetic patients. So if we start from the exenatide to the liraglutide, even the lixisenatide, three of them, and then once in a week we have the dulaglutide. So the four of the molecules in GLP-1, they are available since almost 12, 13 years. And they were not doing the great. So maybe one of the reasons that why it was late and they could not come out with a Ozempic, which is a once in a week semaglutide, once in a week from Novo Nordisk had not come. Now they are thinking that Ozempic should come in a anti-obesity drug. So that will come maybe in a year or two. And as India is a very, very injectable fussy market, people are not very much keen to take or not compliant for injectable. So probably once the semaglutide had come in an oral market, in an oral form, it has been introduced in India in an oral form and not in an injectable form.
The other issue is Tirzepatide is showing very excellent data as you showed and is likely to be approved in future, maybe this year. So will it be used for non-diabetic obesity also, or is reserved only for diabetes and obesity?
So sir, at present the data is for the diabetes and the cardiovascular disease, which I had shown with the surpass data. It is a fantastic molecule, but the weight reduction with this dual and the coming newer GLP-1 or GIP combination will be definitely in future will be used as an anti-obesity agent also, but they will have to prove it as a dedicated obesity trial, not in a diabetic patient trial. But in diabetic patient, they had shown a significant weight reduction. At present, like the semaglutide, after doing his anti-diabetic is an efficacious drug as an anti-diabetic agent, they had shown as a dedicated trial they have done as an anti-obesity agent also. And now oral semaglutide in India also, they are doing slightly at a higher dose. Instead of 14, 25 and 50 milligrams semaglutide, clinical trial is going on all across the world as an oral semaglutide as an anti-obesity agent also. So once the data will come as an anti-obesity agent, I'm sure these drugs will be also approved as an anti-obesity agent too.
And the other issue, how do you look at the future of Cagrisema?
Future of?
Cagrisema.
Yes. So, sir, you know, the future of these molecule, and particularly Cagrisema, will be great because the data, initial data is really very good. We are mainly looking for a side effect or efficacy is very good. But then, you know, the first phase 3A trial will give you whether there is any unexpected side effect, how many patients remain in the retention for a long period of time, and that will decide the future of the molecule. But looking to the data, it looks very promising, and I'm sure it will be a wonderful and blockbuster drug as far as anti-diabetic drug is concerned.
And the last issue, obesity is never cured. It only goes into revision, whether you get a bariatric procedure or a bariatric surgery. So is there any data available on these anti-obesity medications in post-bariatric endoscopic procedure or post-bariatric surgery?
So, sir, there is one data of GLP-1 uses, not with oral semaglutide, because that cannot be given with a relative contraindicated with a patient who have bariatric surgery or stomach is already been cut, because semaglutide get absorbed through that. But injectable liraglutide had a data with a patient with a post-bariatric surgery, not for the regain of the weight. As we know that it is not a GI system disorder. Obesity is a disorder of a brain. Person, you know, keeps on eating, and even his desire for eating is never stopped, and it is the behavioral therapy. It is the modification in his lifestyle and particularly the behavior. It requires psychotherapist, it requires education, it requires motivator also. And if that continuation of motivation with these the molecules like GLP-1 analog, I'm sure you can consider that obesity will be also treated or even cured for some of the patient, but definitely it will be a condition of remission. It cannot be considered like a cure for obesity, because for the patient with post-bariatric also, it recurs.
Over to chairpersons.
Banshi sir, Tirzepatide has shown better outcomes as far as it is compared with 1 mg Semaglutide. So any comparison is there with 15 mg Tirzepatide with 2.4 of Semaglutide?
So whatever the data it was there, which was in comparison, which we had shown, because these are the two different companies who are making the two molecules. So when they have the data to show, but once it will be in the phase 3A trial and once it will be approved, I'm sure there will be many more comparison will come and we will have more future data. And even, real world data will be also published. Like once, and now Semaglutide is available and I'm sure you are also collecting the data, then we can show always that collecting a data of oral Semaglutide, will it be more effective than injectable Liraglutide 3 milligram also? And that type of data will come only once it will be available in the market.
Thank you.
Sir, Banshi sir, flawless presentation. Can you give some insight about that future cost of Cagrisema in India?
All these molecules will be costly.
Yes.
These companies try that for developing countries, as it is the country where everyone has to buy from out of the pocket. Outdoor patient treatment is not insured in our country. And mostly these molecules will come with some premium price, and that we have to accept. There is no doubt about it. And these are the molecules for class, you can say today, it cannot be used for mass. The similar type, like all GLP-1, which was available to us in last 10, 15 years, we could not use it for masses. We had used it only for some class patients. Even there was indication even in the patients who are poorer too, but we can't use it because of the cost. So cost was a major challenge. Similarly, now Semaglutide had come in an oral form, which is also at a premiumly priced, and we can't do much for that. Even company try to get the best price for the developing countries in compared to the developed. But the same molecule is manufactured at the same place and it is given in US and India, the price is different for that. So that we have to accept, and these will be really costly. At present, Semaglutide is costing almost 10,000 per month. So I mean, probably these newer molecules will come costlier than what we are paying just now.
Sir, any contraindication? Any contraindication of amylin analogs?
So amylin analogs, the contraindication one is always with the history of pancreatitis. Still, it's a caution for all of us to understand that all GLP-1 or even amylin analog are not to be given, or with the cautious, they should be used in the patient with history of pancreatitis. Otherwise, if the patient is intolerant, that's an only probably you can say that can be a contraindication or a caution or relative contraindication.
Dr. Abhishek, any comments? Dr. Abhishek?
Sir, thanks a lot. Banshi sir, flawless presentation. Banshi sir, one question, like GLP-1 analogs are not like officially been indicated for the management of obesity, but can they be prescribed in a pre-diabetic obese patient?
It is GLP-1 in India also, Abhishek. It is not like that 3 milligram, the Saxenda, which is approved in US, the same is also approved by DCGI. They are not promoting it. It is not available in the form of 3 milligram. Now, 3 milligram is an official for anti-obesity agent, it is GLP-1. The other, which is 1.8, 1.2 or 0.6, or you talk of Liraglutide or any other molecule, is an officially DCGI approved as an anti-diabetic. Similarly, the Ozempic is also at a lower dose, is an anti-diabetic agent, slightly at higher dose as an anti-obesity agent, which is approved in US market. And probably Ozempic will be also approved in our country as an anti-obesity agent, probably the first molecule which will be approved and marketed also, not this by next year. This is what their plan is. But at this point of time, we are using it as an off-label, and GLP-1 are used in the off-label as an anti-obesity in a pre-diabetic population, in a diabetes with overweight and obese patient. So everywhere we are using, and we can explain the patient that this has been approved in this dose, but we are giving with this dose which is not approved as an anti-obesity agent, but we can use it.
Thank you, Dr. Banshi Saboo.
Thank you, sir.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.